I'm Chantil Jeffries. I'm the APP Clinical Director at Gastro 1 in Memphis, Tennessee. I have over 28 APPs, been in clinical practice in GI for 24 years. I have my doctorate in nursing practice and then did something weird, went back and went to law school, so I have my Juris Doctor as well. And when you're, I just wanted to jump in there with all the psychological things, because I'm getting my master's in clinical psychology right now, because it's so tied to all of these GI issues that we see, especially gastroparesis, functional dyspepsia, IBS, things like that, IBD. So that's why I decided to get that degree as well. I've been using the Enterra since around 2015.
We're going to go through a few case studies and give you a chance to ask questions and give your opinion. So in this case, it's a 61-year-old woman who presents. She has type 2 diabetes. She's had it since 2000, so more than 20 years with diabetes. And we start to ask, well, do you have any complications of diabetes? Yes, I have neuropathy. So you think, okay, there's some end organ damage here. This is possibly a gastroparesis situation. For the last couple years, her glycemic control has fallen off, and she's at an A1C of 11%. So that's in the range where you can have abnormal gastric motility and sensation problems. She also has hypertension. She has had a cholecystectomy, but it was like 20 plus something years ago. It was a long time ago. So that's probably not related. And she's had a hysterectomy. She presents with the typical symptoms of gastroparesis. And because she's been so sick in the last 4 to 5 months, she's actually lost quite a bit of weight. So she's become malnourished. She's had several admissions. She's been struggling with dehydration, electrolyte derangements, and just her symptoms in general. If we look at her med list, we're thinking about, are there any medications on here that would slow her gastric emptying? And importantly, we find that she's not using marijuana. She's not on a GLP-1 agonist. And she is not using any opioids. None of these medications are super likely to be causing her gastroparesis, but some of them could have some nausea vomiting side effects. And by the time she got to our clinic, she had already been put on TPN that she was so sick from her disorder. So this is what her diagnostic steps were. She had her upper endoscopy. She was found to have fundus gland polyps that wouldn't cause gastroparesis. She did not have H. pylori, importantly. And she did not have celiac sprue. Her gastric emptying showed 62% retention at 4 hours. That's a really bad delayed gastric emptying. Her upper GI X-ray showed that she had a hiatal hernia, and on CT scan she had no obstruction. So we're in the realm of making that diagnosis of diabetic gastroparesis at this point. We checked her for pancreatitis, and she did have low sodium, and her glucose was 181 on the day we tested it. So she had tried all of these things. She had been in the hospital so many times. She had been exposed to haloperidol. She had tried IV Phenergan, metoclopramide. She did tolerate metoclopramide, but it was not effective. She tried ondansetron, azithromycin as a correlate to erythromycin, the scopolamine patch, acid reduction, and none of these things worked. She had tried a completely soft white diet, you know, the white bread, white pasta, rice, very soft foods, and eventually TPN was started. Now, in my practice, I wouldn't go straight to TPN. I would probably have started with enteral nutrition, but she came to me on TPN from an outside institution. So in this case, when she came into my clinic, she was one of those patients who told me she has nausea vomiting immediately upon eating, like she swallows and she immediately throws up. And I feel like that can sometimes be a little bit difficult to differentiate from like regurgitation, you know, maybe something else is going on. She didn't have as much of like that delayed emptying where she told me she vomited food like 8 hours later. So before I cinched the diagnosis, I went ahead and I just did this upper GI X-ray. Specifically, I wanted to make sure she didn't have like a paraesophageal hernia or some kind of surgical issue that we needed to address. So she did have just a sliding, simple hiatal hernia, a little bit of esophageal dysmotility. And remember, we talked about how liquids, even in established gastroparesis, they may go through just fine. You can also see gastric retention of liquids in gastroparesis. So it's something to look for, but normal emptying of liquids does not dissuade me from a gastroparesis diagnosis. but no gastric outlet obstruction, no partial bowel obstruction, no paraesophageal hernia. Okay, so we're gonna do poll everywhere. So in this case, what do we do? And just like in our regular practices, you could do many different things, right? And there's not always a right or wrong answer, so I kind of want to know, well, in your opinion, what would you do next? So I think we have a good case for diabetic gastroparesis here. Would you convert her TPN to tube feeds instead? Would you try adding additional antiemetics? Because we haven't done the whole list of antiemetics. Should we try all the antiemetics? Should we consider Enterra? Or would this be a good candidate for a pyloric intervention in your opinion? What would you do in your clinic? So it sounds like most people in the room feel like maybe we should try placing Enterra. A few have suggested maybe we should try some additional antiemetics because she hasn't had all of them. And then there's a group, a smaller group who's thinking maybe a pyloric intervention. And none of these options are wrong. Okay, so yeah, these are all options we could try, and we might do multiple. We might say, I'm going to give you this antiemetic, but I'm also referring you for Enterra, or I'm going to have you talk to my therapeutic gastroenterologist about a GPOM, or we're going to try this, and then we're going to do that. So these are all right answers. So in her, we did place the gastric neurostimulator, and this is a typical operative note, so they're going to do an endoscopy during the surgery. They're going to place the Enterra, they're going to install the neurostimulator subcutaneously, and then they're going to program it. So they're going to come out of that surgery at what we call nominal settings. So you can see the amplitude is at 3 milliamps, voltage of 2.5, and the impedance has been measured. We're going to talk about what those mean today. So this is like a slam dunk case because she came in and she was an early responder, which is so great to see. At 4 weeks after surgery, she felt like she was 95% better from a nausea perspective. She had been vomiting 10 times a day and went down to 3 times per week. She was actually eating. Prior to this, she was eating 200 to 600 calories per day, and now she's eating 1,200 calories per day. And she had already reduced her TPN by 50% by the time she came back to see me. So this is a really great response. So at that first visit, we didn't make any changes because she was doing very well. She definitely had more than 80% improvement, so we left things where they were. I had her come back at 6 months, and at that point in time, she had actually started to gain weight again. And she was one of the patients who was obese at baseline, so she was actually excited to meet with a dietitian to talk about diet control of her diabetes and control of her weight. And she was very engaged in that and just very thrilled with her outcome.
So this is another one of Diana's patients, but I have seen similar patients in my practice, but we'll go over case 2. This is a 25-year-old female. She has a 10-year history of nausea, vomiting. She experiences daily epigastric pain that she states is constant. She has nausea and vomiting that comes and goes, but she will typically vomit bilious material. She did have delayed emesis. So she has mixed IBS with alternating constipation and diarrhea with abdominal pain, which is different than the epigastric pain that she's experiencing. The lower abdominal pain improves with defecation. She's had multiple diagnostic studies, as is typical for this type of patient. Her EGD revealed reactive gastropathy, but H. pylori was negative, and biopsies were negative for celiac sprue. She had an abdominal ultrasound that was normal, and then went further to have the HIDA scan to determine the function of the gallbladder, and it was also normal. She had gastric emptying studies 2 years prior with a 4-hour retention of 11%, and then it was repeated, and her 4-hour retention was 41%, so significantly abnormal. She also had an MR enterography that didn't show obstruction, which I'm impressed with because we can usually only get IBD patients to do the MR enterography, and we only have like one radiologist in town that's really good at it. So she's had multiple medication trials. This is often what we see with these patients. She was tried on metoclopramide, and she didn't tolerate that. She had some muscle twitching. Sometimes you see muscle twitching when you tell a patient that may occur, but this may have been true for her. Erythromycin wasn't effective. She was on Dantatron, which helps with the nausea, but if she has severe nausea, she takes promethazine, and it causes sleepiness, of course. Dicyclamine has been tried, and it helps some with the lower abdominal pain. She has the constipation, previously tried and failed all the usual suspects, the Motegrity, Linzess, Somatiza, and Trulance. But she has responded to Miralax. She's on a PPI for GERD, and she's on amitriptyline titration for pain. Abdominal pain is the most persistent symptom here. Nausea responds to antiemetics, and she's able to tolerate soft, solid foods between her attacks of nausea and vomiting. Do you think she's a candidate for a neurostimulator? This is great. You did follow the logic of what we were talking about, so she's probably not a reasonable patient for Enterra because pain is her predominant symptom and the nausea vomiting is intermittent. So it's more reasonable to try and maybe neuromodulation, diet, and pain psychology. So the patient is now 2 years into her treatment plan, and she's on amitriptyline, 40 milligrams at bedtime. That helps to control her chronic pain. She's on an IBS care plan, which includes fiber supplements, antiemetics, treatment of the constipation aggressively. She's on antiemetics as needed for the nausea, and she is tolerating a gastroparesis diet.
So we're going to run through one more case. Hopefully we're kind of trying to put up some cases where you're thinking about is what's the right next step, because it's not always the right next step to put Enterra in if someone is presenting with pain. And pain is often part of this person's presentation. So I have a very direct conversation about what is the worst symptom you're having, what is the most frequent symptom, what is the symptom that's affecting your function and quality of life. So this is a 33-year-old who's had a gallbladder surgery, has ADHD, asthma, GERD, sleep apnea, fibromyalgia, so we've got a pain presentation there, fatty liver, and they have medically refractory gastroparesis, uncontrolled GERD, and IBS, so a real mixed bag, and this really reflects what we see in our everyday practice, right? Daily vomiting for 10 years. You can imagine this person has a high dental bill. Worse for the last few years. They're vomiting 3 to 4 days per week, but when they do throw up, it's 4 to 5 times per day. So they're really not able to work or have a functional life. They're full within a few bites of food. They have a lot of postprandial fullness, nausea, and vomiting. They've lost 80 pounds because they can't eat. They are not using any offending agents. And a cholecystectomy was done 2 years ago. So they've been sick for 10 years, worse for 3 years. A cholecystectomy was probably done in hopes of improving symptoms. But it's not like the gastroparesis started after that surgery, so I'm not thinking that this is a cholecystectomy-related gastroparesis. So they've had an endoscopy, no mechanical obstruction. An optimized solid food gastric emptying study shows 55% retention at 4 hours. And the CT scan shows no obstruction. They've also had an upper GI x-ray. Sometimes if you lose a lot of weight, you can experience weird things like superior mesenteric artery syndrome, which can obstruct the duodenum. So they've had an upper GI x-ray to rule that out. Now, they did show that the patient had quite a bit of regurgitation, but they had normal liquid emptying. They have tried prokinetics without effect. They have tried antiemetics. Ondansetron and promethazine are their go-tos as a combination approach. They do already work with a dietitian, and they've been compliant with a gastroparesis diet. They have tried Imodium, Pepto-Bismol, fiber for their lower GI IBS symptoms. They've tried a low FODMAP diet. They've even tried rifaximin, which did help with their IBS symptoms. But the nausea vomiting persisted. We've maximized our GERD management, and we've tried anticholinergics and tricyclic antidepressants for pain. So in this patient, are they a good candidate for Enterra? So it looks like we're on the same page with this patient. So she did get a gastric neurostimulator. These were the surgical settings. So amplitude of 5 milliamps with a voltage of 3. And they always will do that endoscopy to ensure that there's no lead penetration into the stomach. At 2-month follow-up, she had improved nausea. It was now rated as mild nausea, sometimes moderate on a different day. And instead of every single day, it was 4 times a week. Vomiting 0 to 3 times a week. So before she was vomiting, 3-4 days out of the week, 4 or 5 times per day, and now 3 times in an entire week is a dramatic improvement. We went ahead and made an adjustment to her neurostimulator because she was still throwing up and she was still experiencing frequent nausea, so we turned her voltage up by 1.5 volts. And we documented that she's still experiencing frequent nausea, but instead of being severe, it's moderate, and instead of vomiting 1 to 4 times a week, she's vomiting 0 to 3 times a week.